how we can put those things together to make an overall sense of people's health and well-being. All right, so some of the issues of patient-provider relations are issues that we talked about related to patient perspectives. When somebody is out trying to seek care and support, some of the ways that they might feel like they're not being listened to, some of the ways that they try to advocate for their needs, and some of the ways that they apply their needs to their everyday lives. We also talked about how providers are oftentimes faced with a difficult and strenuous health environment. You know, the process of going to med school, doing a residency, and ultimately being in a professional position to provide care can be a major challenge, along with having to navigate and juggle a lot of meetings with patients. So in talking about and shaping the context of patient-provider relations, we talked about a model. So let's see if we can get this one first. So the blank model involves being capable of understanding information and making a judgment. Be about receiving information that might relate to things like health. Not quite. So the biomedical is an approach to how we think about medicine and care. One begins with an I. Last week, we talked about the Tuskegee syphilis study and about how this was not provided. Informed consent, yes. So informed consent is a model about thinking about patient-provider relations that's important, and a model that we use to this day, right? It means that people need to understand and know what it is that they're signing off on if they're receiving a surgery or care. Informed consent also means that people are given a full picture of the health or science information. They're given the whole story. And it also means that they're able to back out at any time, right? This informed model is crucial because when we're trying to provide, receive care, patients need to be able to make decisions on their own about what care they're receiving and how medical interventions are happening and impacting their bodies, right? And that is part of developing that trust in those relationships. Obviously, there are exceptions as it relates, for instance, to somebody such as a family member who might make a health decision for somebody that's unable to provide a health decision on their own. For instance, if somebody has suffered a major surgery or is in a comatose state, right, that might be a decision made by a family member, or something such as a will might be a determination too, including a living will that could indicate what somebody would want done to themselves in those circumstances. But this is an important idea, right? We're making decisions about health on our own agentically, knowing some of the risks and problems that can come out if we don't have those informed decisions. So for today, we'll be transitioning from patient-provider relations, those important interpersonal relationships that healthcare providers and patients can have, and that framework for helping us to understand these, to instead start talking a little bit about the presentation assignment for the class, issues of diversity and the need to consider diversity when we're thinking about health and science-related issues, and then also how things such as culture can shape the ways that we understand health and science as well. So as I mentioned for the beginning of class, we have the health and science disparities presentation that is coming up on May 2nd and 4th. So Monday and Wednesday of week 6 are the times for that presentation. I'll be posting the rubric that just kind of goes through in a grid way the expectations for that assignment by Wednesday's class. That way you know what to expect and that you can start preparing. This is a 6 to 8 minute presentation, and I'm also asking you to submit an outline that goes over the main things that you'd be including. I would recommend including some type of visual aid, such as slides, to help you out. And the real focus here, and this week's discussion will directly help you in preparing for this assignment, is to think about a particular population that has been disproportionately impacted or affected by a health issue, right? As we'll talk a little bit about for today, the issue of disproportionate impact does not necessarily necessarily mean that a population is biologically predisposed to be at a greater risk of an issue or illness just on the basis of things like their DNA. For instance, there's a lot of cases in issues surrounding race where culture, right, and socialization rather than biology has been a determinant of health disparities and issues. So there are also some cases when we think about things such as sex assigned at birth, where there might be issues that do disproportionately impact the population in a more biological capacity. But in either one of those cases, I want you to identify a population that has been significantly or disproportionately impacted by a health issue. An example of the more biological side could be people assigned female at birth who might be at greater risk of breast cancer, right? And what I want you to focus on is how communication might aim to support that population or to address the disparities with which you identify. For instance, we could talk about some of the ways in which members of the LGBTQ+ community have been disproportionately impacted by HIV/AIDS, right? And the ways in which issues like health campaigns have developed in response to some of those impacts, right? We've also talked about things such as pain management, medication, and care that oftentimes historically has been less provided to patients of color, oftentimes on the basis of stereotypes about pain tolerance. So what I encourage you to do is to think about a health issue that impacts the population disproportionately in a way that you find really interesting or thought-provoking, or you'd like to explore further. We'll be looking at some examples of this in class today, and we can think about a lot of different components of identity that could go into making that determination. So we'll be going over several examples of this, and the article this week outside of the textbook is one that explores disparities in healthcare too, that we could look at in a little bit more detail. But again, if the focus for this class is on how health and science communication can bridge those barriers and gaps, then this assignment can help you to figure out how communication can support addressing these issues too. So before we get into some of the new stuff for today, does anybody have any questions about anything in the class at this stage that we've gone over so far? Awesome. Oh yeah.
Does the presentation have to be about a health issue?
So it could be a historical example, right? It doesn't have to be in the moment right now. If you have kind of a good historical basis to look at that. Yeah. That would be great. Yeah. We'll have some opportunities to brainstorm this week, but if you already have some ideas or you want to start outlining or putting that together, I'd love to look at that. I'll look at examples like outlines or topics or even a draft if you want to send anything to me in advance for sure. Awesome. So good questions. So as we start to think about some of the issues related to diversity in healthcare, one of the things that I really kind of want to front this discussion with is that when we come in, right, into health and social relationships, we're coming in with a lot of different identities put together. So we'll be talking about things such as race, gender, disability, age, and so on. But for many people, right, those things are interacting and overlapping with each other. One framework that's been used to describe and think about these issues has been the framework of intersectionality. Dr. Kimberly Crenshaw, who is a law professor, came up with this concept to describe the experiences of Black women in the legal system in the United States. But it deals with the idea that the experiences in health and in science across those overlapping components of identity might look very different than for instance, Black women compared to Black men or white women, right? So those are important considerations as we're overall situating this discussion. So when we think about issues of diversity and culture in healthcare, right, there's a few things that might come up for us as to why these things are really important. One of the issues that comes up when we're thinking about issues of health and science and care is the idea that historically people who are similar to each other tend to oftentimes have a better understanding of each other, right? That's oftentimes based on assumptions about culture, background, and experience. And what that ultimately might mean is that when we are coming in and serving a diverse group of people from a patient or provider perspective, we might have gaps our understanding of cultural differences or issues. For instance, if we're making an assumption based on socioeconomic status about somebody's ability to consistently pay for healthy food, right, then that gap might inform how we're providing care. Similarly, another issue here is that stereotypes and bias might play into our assumptions about things such as care and need. One example of this has been in the context of developmental disability or difference, that oftentimes developmental disabilities have been disproportionately diagnosed or identified among populations that are white and male, right? For instance, diagnoses of things such as ADD, ADHD, autism, and so on tend to disproportionately be given to men. And that's oftentimes meant that people who might receive a positive diagnosis sort of fall through the cracks. So we also might have different stereotypes or assumptions about who does or doesn't fit under certain diagnoses. And another issue has been that things such as historical marginalization in the healthcare system can also lead to significant issues surrounding access and quality of care. Again, we looked at the Tuskegee syphilis study as an example and case study of the issues of providing care. But I think another historical example that I think is really worth considering has been the diagnosis of hysteria that was historically used to refer to women. Is anybody familiar with like hysteria as a diagnosis or its usage historically? A couple of you. So I am going to share a short video that talks about and breaks down some of the elements of history surrounding hysteria that I think is a good perspective to add here. And I share this video as an example of some of the ways that issues of marginalization, access to a diagnosis, and biases in care can ultimately lead to some pretty negative health consequences and connect at a social level as well.
When you hear the term hysteria, you might think of a frenzied group of people, like shoppers on Black Friday. But for a long time, that word meant something different. Hysteria was a mental condition attributed specifically to uterus problems, and it became a sort of catch-all diagnosis for any women's health problems doctors couldn't figure out. The term, which even came from the Greek word for uterus, was coined by the physician Hippocrates around 500 BCE, but it was acknowledged as far back as ancient Egypt 1,000 years before then. It's no longer recognized today, but it has a complicated history full of strange explanations, including one that said that the uterus just sort of wandered around the body, causing problems. Sometimes you're just extra thankful for modern science. Even doctors today can't always figure out what's going on with a patient based on their symptoms. And unsurprisingly, this happened a lot more when we didn't really understand the human body. So for thousands of years, stumped doctors wouldn't just admit that they didn't know it was happening, and they would diagnose their female patients with hysteria. The list of symptoms for this condition could include almost anything, including anxiety, melancholy, bursts of emotion, headaches, tremors, even convulsions. Anything they couldn't figure out got lumped in, and physicians throughout the ages came up with some surprising explanations for hysteria. Up until around the 20th century, almost all of them blamed the uterus. This might seem somewhat silly now, since we know that the uterus mostly deals with reproduction, nurturing, and housing fetuses. But at the time, physicians didn't really know how all that worked. So the most popular explanation, and the weirdest, was that hysteria was caused by a wandering uterus. Apparently, someone's womb could just get bored and move around. It could crush their intestines, lungs, or heart, or create an empty cavern in their body, all of which would supposedly cause those random symptoms. One Greek physician called this phenomenon uterine melancholy. The good news, though, is that this wandering uterus could be easily cured or prevented. Many believe that it was caused by these women not having a regular sex life or not being pregnant often enough. So the solution was either to have more babies or to have more sex in general. According to the societal standards of the day, they just had to get married first. So real simple cure. Another arguably stranger cure was to use different scents to put the uterus back in place. For some reason, physicians believed that it was attracted to pleasant smells and repelled by foul ones. So if your uterus happened to wander too high up into your body, you could sniff something unpleasant, like ammonia-containing smelling salts to drive it lower, or you could use vaginal perfumes to coax it back into the right spot, because that's totally how that works. Starting in the 1700s, some researchers decided that hysteria was neurological and had nothing to do with the uterus. But it took a lot longer for the public to catch on. Even during the late 1800s, many women carried around smelling salts to revive them when they swooned or fainted, the idea being that the wandering uterus had caused them to pass out. In reality, it probably had nothing to do with their reproductive systems. Historians believe that anything from tight corsets to societal pressure could have been responsible for all the swooning back then. But if nothing else, the smelling salts are pretty good at reviving unconscious people. Smelling salts are actually a mixture of ammonium carbonate and perfume, so when you waft them around, they release ammonia gas, which can irritate the linings of your nose and lungs and cause you to suddenly inhale. That will likely snap you back to consciousness, no uterus adjustment required. There were other quick fixes for hysteria too. Around the 1870s, a device was invented to help women who couldn't get enough sex in their lives: the vibrator. Widespread views on hysteria finally started changing around 1890 or so, when everybody's favorite psychoanalyst rolled in, Sigmund Freud. Freud had learned about this condition from other prominent teachers, and after finding a few case studies, he helped popularize the idea that hysteria was neurological and therefore must apply to all sexes. But then, in true Freud fashion, he suggested it was caused by someone not having a mature enough libido, which led to them not having enough sex, which is also just not a thing. Although most people abandoned the uterus idea after that point, hysteria didn't really fall out of pop culture, at least in the West, until 1980. Then it was removed from the third edition of the Diagnostic and Statistical Manual of Mental Disorders. The DSM is the manual clinicians use to guide their diagnoses, so once hysteria was out, it was no longer considered an official condition. Today, many of the symptoms traditionally associated with hysteria are linked to things like clinical anxiety or depression instead, and hysteria got replaced by a kind of catch-all diagnosis called conversion disorder. That's when a patient has definite neurological symptoms like paralysis or blindness without any discernible cause. So one thing's for sure, it definitely has nothing to do with your uterus getting up and walking around your body. Feels like that should have been something we could have figured out in those hundreds of years that we thought that was a thing. Thank you for watching this episode of SciShow.
So an interesting, right, example, and a lot going in regards to the ways that we can think about or define issues of health. One of the issues here being that obviously at the time, there was some pretty outdated information surrounding health and the ways that we diagnose medical conditions, things such as smelling salts and solutions for conditions, obviously were antiquated by today's standards. But the observation that this hysteria as a diagnosis was used and included in the DSM until 1980 is an important consideration in thinking about disparities in access to research and understanding of medical technology and conditions. One thing that was not included in the video, but it's also some important context, is the association between hysteria and institutionalization, right? Oftentimes, if women were experiencing an array of medical conditions that might have been completely unrelated, for instance, in addition to mood or personality related conditions, things such as cancer or heart disease or other related conditions were kind of lumped together in the hysteria diagnosis and weren't really receiving care or attention in the same way, right? The idea of hysteria being used as a catch-all for a variety of conditions that were not that was one really big issue. And another one was that institutionalization, right, or putting people into medical facilities was generally not seen as a useful strategy or approach. That you put somebody in a hospital because they have hysteria or they're hysterical, and that's a way of excluding people from society. Not to say that medical institutions or spaces are negative in of themselves, but that it was disproportionately used in lieu of providing care or support. So the very gendered diagnosis and term of hysteria to describe an array of medical conditions didn't really receive the care or research or attention in the same way, which led to some pretty serious medical consequences, is an example of the need to account for diversity, whether we're talking about gender, sexuality, and so on, and thinking about both care and cure. Also, right, the kind of gendered element of suggesting solutions for things like hysteria. Oh, you just need to have more kids, right, are examples of the gendered consequences, stereotypes, and bias that prevented a lot of more substantive care for women at the time. So an example here of our need to address diversity in culture and healthcare, given the negative consequences something like a catch-all diagnosis can have, right? So when thinking about this, one important way to think about addressing issues of diversity in care is this idea of ethnocentrism, right? So there's a rhino here who's painting, but of course he sees his tusk, and so that's the idea that the painting in the world must include his tusk. As it says, having a hard time seeing past your nose is a kind of silly example. But ethnocentrism is a major issue in healthcare. It's not necessarily something that's intentional, but ethnocentrism is something that we sort of have to constantly unlearn if we're thinking about ways to engage with and support patients from diverse perspectives, right? The idea here is under ethnocentrism that we tend to believe that things that are familiar to us are more correct, they're more moral than things that might be outside of a realm of familiarity, right? The idea, my culture is better, my background is better, I'm a part of another culture than this one, and therefore this culture is backwards in its beliefs or approach, is one way of approaching or thinking about this. Ethnocentrism, of course, is a problem in care because we're oftentimes making assumptions or stereotypes about other people, and we're not necessarily considering the needs or concerns that different populations could have, that we leap to conclusions based on what people need or who people are that we're serving based on very limited information. For instance, when I was younger, I had a low blood pressure condition, and when I went to see a doctor about it, they were trying to attribute it to like a social or developmental disorder, and I was like, no, I have something else, right? So leaping to a conclusion based on assumptions about the person can lead to a lot of gaps that a provider has about care. We think back to last week and the video showing the interaction between the doctor and patient. What would happen, right, if the doctor told the patient, oh, you're not really having a headache, you're just feeling hysterical or you're just stressed, right? That would potentially lead to that patient suffering an even worse condition or having their life at risk. So it's important for us to push back against the assumptions or shortcuts that we might be making. As human beings, right, we're seeking patterns. We enjoy patterns because they help us to predict and explain the world. And so oftentimes we look for patterns in human behavior, which of course can cause issues of stereotypes and bias that we might assume based on things like gender or race, whether or not somebody's doing healthy behavior. Those, of course, are examples of problems too. And so these can reinforce prejudice, right, or judging, rushing to a judgment or expectation about other people as we're trying to provide care and support. In thinking about health and science in terms of intersectionality, right, multiple overlapping identities and experiences that come together to make us who we are, one of the important ones for us to consider is socioeconomic status or class. This is especially true when we start to consider things such as the cost of insurance, of care, but even if we branch out a little bit further, who has access to the ability to regularly attend something like a doctor's appointment? Can somebody afford to miss work or be able to do so? And does somebody have access to the information that they need in order to make informed decisions about their health? So there's important considerations here about how we navigate socioeconomic status and the assumptions that might be made based on class, right? There's, a media example I find kind of funny in thinking about this is if you've seen the show Arrested Development, right? The characters are all like very wealthy, and there's a character in the show that says, oh, let's get a banana. What does it cost? $10, right? Being out of touch or not understanding two issues of socioeconomic status is a problem. Socioeconomic status can include things like income, education, and employment level, right? So somebody's access to educational opportunities, including school, and perhaps the quality or opportunities presented in a school play a really big role here. Perhaps unsurprisingly, people of lower socioeconomic status, by putting those things together, are less likely to have good experiences in healthcare. of lower socioeconomic status are less likely to afford appointments, to afford quality doctors, to afford the basic information that they need, and might not be able to decipher or understand health information in the same way. Socioeconomic status does not mean that somebody is more or less intelligent, right? It's not a question of cognitive ability. It's a question of the resources that somebody does or doesn't have that allow them to make decisions surrounding health issues, right? For instance, if you were to read through a brochure that was talking about risks associated with cancer and the need to do regular cancer screenings, like a colonoscopy, right? People of lower socioeconomic status would have greater difficulty reading through or understanding the content in the brochure, and therefore would be less equipped to know when and how to receive screenings, right? Health information and knowing what to do with that information is a really big factor. And again, that's a problem for providers because oftentimes providers are kind of towing that line between being patronizing and maybe a little bit too babying of the person, or of being overly technical, jargon focused, and losing something. One of the challenges that we have to think about when we talk about issues of health and science then is how do we communicate the appropriate amount, knowing that somebody whose heads that we're speaking over might not choose to let us know, right? Sometimes because people are afraid of being seen more negatively, or they're worried about embarrassment, they might not choose to share information that they don't understand, right? They might nod their heads or say, oh, I agree, I get it, but not understand what the provider is telling you. This ties to a really important idea and something that I think is crucial for us to think about in this class, whether you're going into professions related to health and science or not, and that's this idea of health literacy, right? We know that issues of health have a very specific vocabulary associated with them. We talked about appointments, we talked about diagnoses, we talked about managed care, patient-centered care, informed consent. There's so much terminology that it's essentially its own language and its own vocabulary, right? So health literacy in this way is referring to the skills that we have. And there's a lot kind of here to digest together. Health literacy refers to our cognitive, right, our mental and social skills that we have developed that will determine our motivation and our ability to gain access to, understand, and use information that promotes and maintains good health, right? So there's a few things to unpack here. So health literacy involves us developing skills, okay? That helps us determine motivation. So what types of behaviors or things do we seek out? If we have good health literacy, then that means that we might understand the value and utility of doing a regular cancer screening, right? Because we know that we could detect something early and be at much less of a risk of having a terminal illness. Our ability to gain access to information is important too. So for instance, depending on where we're located geographically, how easily we can access a hospital and medical facility is one factor. Ability could also be about our ability to financially pay bills, receive insurance, or make payments. Gaining access to, understanding, and using information, right? So are we able to receive that information from a health professional, from something like a chart that's provided online? Do we know what's being used here, right? So communication is a two-way street. It not only means that the patient can make sense of and understand the information, it means that the provider is able to give that information in a clear way. There's something that's discussed and known as plain language, right? A plain language version is using a sort of conversational and not jargon approach to sharing information. So oftentimes the sort of industry standard is that health professionals need to provide plain, clear language so that just about anybody is able to understand the information and that they can use that information. And again, deciphering and making sense of health and science information is a crucial thing that providers need to be able to get. For instance, if somebody is using DNA, like a 23andMe test or Ancestry, or like, those DNA tracking packets and kits that you get, how you're deciphering and using that information is through that exchange with the provider. So health literacy requires understanding of language, right? That can be interpreted in a lot of different ways. Are you fluent in and understand the language that is being spoken by professionals? I'll never forget the time that we were traveling to a debate tournament in Berlin and get a student who had a severe headache and needed to go to the ER, and none of us spoke German, so we had a really difficult time helping her to get her support needs met. We were able to help her out, but that was a major barrier that we encountered through that experience, right? Also, to understand some of the more technical and specialized language. Your access to information, right? What is available to you? Something like secure access to an internet connection or smartphone could differ depending on location too. Your interest, right? Health literacy means caring about or being interested in your health. Oftentimes that grows with time and age. For instance, teenagers, and one of the challenges of health campaigns or health efforts to reach teenagers has been engaging with things like interest. One case study or example we could look at that to explore further is vaping, right? And how it's been a lot harder for health campaigns to target teenagers surrounding the risks associated with vaping, knowing that there's less interest in health-seeking behavior among younger populations. Social skills, right? Being able to talk about and say, hey, I don't know this, or I'd like to ask a little bit more about this. Hearing and vision, can you cognitively understand and sensorily pick up on the information that you're receiving? Again, the informed consent model means that a patient needs to fully understand the message. So if you're presenting a document to somebody that's legally blind, we need to do something such as having access to an audio version or having additional support, such as a larger font version or more accessible version for somebody to read. Knowing how to apply or use the information, right? So understanding what something like a diagnosis means in terms of medication, treatment, and care, and being willing to put that information to use. You have high cholesterol and blood pressure. Here are the things that you need to do, and health literacy would mean agentically choosing to engage in those behaviors. As mentioned, right, people with lower health literacy are not always empowered to speak out about that. For instance, if you find that a doctor's talking way over your head, you might not choose to share or say, hey, I don't understand, because you don't want to embarrass yourself, or you feel like the doctor will think less of you. Issues of power and dignity are important, and so a provider creating an open environment for somebody to share that they don't understand or can't fully follow through on information is really important. One example of some of the ways that patients can make their experience better is what's known as the Ask Me 3 system. And this is a way that oftentimes patients can navigate questions related to their care while still maintaining the sort of dignity and respect that they might want. What is my problem? Figuring out what the issue is that you need to have resolved, like a diagnosis. What do I need to do, right? What are the practices or behaviors that I need to engage in? For instance, if somebody has broken their arm and they know that they need to take care of it, such as a sling, what does that maintenance look like? And why is it important to do this? Studies suggest that we are way more willing to engage in health-seeking and healthy behaviors if we know why those behaviors will help us do better, right? So really showing us that relationship of do X to prevent Y or to promote Y is important. To help with health literacy, one thing we can do is to be attentive and respectful, right? Showing and noticing if somebody does not seem to be understanding or following through on information is important. using things such as an assessment. Again, a lot of health and medical centers use things like charts that will online give you an assessment of health and of your previous visits. Letting patients know what to expect, for instance, what to expect out of a meeting or checkup, or what to expect in navigating a medication are useful. And then lastly, having patients be explicit about their feelings or questions. One way to do this in an open-ended setting would say something like, how are you feeling so far? Or is this making sense to you? And doing regular check-ins like that are a good way to promote health literacy by, again, giving that open-ended context for people to express their concerns. So what I want to have us do is have partnerships or groups of 3 to look at a scenario that applies some of the things that we talked about related to health literacy. So in this scenario, Carl recently turned 50. His family has a significant history of cancer, and he is being encouraged to attend regular cancer screenings, such as colonoscopies. But Carl is very distrusting of doctors. He believes that doctors leave you feeling sicker than when you first arrived. So if you were a provider, right, such as a doctor that would be meeting with Carl, what could you do, first of all, to improve Carl's health literacy, given what we've defined and talked about? And then secondarily, how might some of the issues in culture, including ethnocentrism, potentially impact, from what you know about Carl, how he might approach health? So let's go ahead and have a partnership back here, partnership up here, partnership these 2 rows, a partnership back here, and then a group of 3 through these rows. Take some time to talk through these prompts, this prompt and these questions together. You might take some notes, and then after a few minutes, I'll ask the different groups to share what suggestions you have for navigating Carl's situation. We don't have to. We can say yes.
And the trying is that public extent, that should be a long process. It might be recommended to have it down on their own. A lot of people, they don't follow up on it, or in some instances, they might not even be able to do it. So, but they mismanage things. There's a lot of good places, depending on how. Yeah, there's a lot
Having a negative experience, people feel empowered to why regular kids. I guess this is.
Getting the point across.
Yeah.
Take a couple more minutes on this and I'll ask each of these groups to share. All right, go ahead and wrap up your current thought or idea in your group. All right, so let's talk a little bit about this situation with Carl, both in terms of what we could do for Carl's health literacy and what we might think in regards to ethnocentrism. So let's hear from each partnership or group of three on how they address these questions, starting here on this side.
When it comes to trying to improve Carl's health literacy, there's kind of, I guess, two phases to it. In the short term, given how serious this issue can be, given Carl's age, like the history of this, whatever doctor is speaking to him kind of needs to bring him up to speed as much as possible without being demeaned. He's clearly an untrusted person. The point is not to shift his entire focus of doctors in one sitting. It's just to make sure he understands the seriousness of the situation and work through it further. And that's the other thing is to try and get him to improve his own health literacy long term, have him do his own research, let him figure this out at his own speed. Maybe he speaks to some family members that might have dealt with cancer or something like that. And as regards to ethnocentrism, that really just depends on what Carl's own culture and race it is. We don't know all those details. But again, he might have had a bad experience with doctors in the past. some of his family might have had horror experience, he might be trusting of different cultures and whatnot. But in general, like, it just depends on his situation and like his past experiences, I guess.
Great, thanks, Garrett. Let's hear from partnership back here.
So we said, to, as I said, pretty much be educated about how this advance, how they left with it. Making sure to engage in like simple terminology and be really empathetic with his perspective, which is through like the body language and using like the brochure to grab something that really. That's especially from. You can see how his age or his family member history would, could have an impact on his perspective. And additionally, you might think that his family history of having cancer could like impact the doctor's perception of his. Almost so it's more like reassuring.
Yeah, right. Like I'm seeing a trend here of sort of helping the patient feel empowered in a lot of these situations. Thanks, Stephanie. Let's move here to the front.
So, for instance, right, this what another group just said, for essentially being attentive and respectful and empathetic when speaking to Carl, and trying to create a comfortable environment where he feels like he can ask questions freely without judgment. So that's like the doctor's body language, and like his tone of voice, and just like actual like office. And then making sure to like explain to Carl like exactly what's going to happen in the appointment, so like what they're going to discuss, and then like any procedures that have to happen, exactly what will happen. Especially just because like one of the suggested cancer screenings is colonoscopy, which is extremely invasive, and for someone that might just that distrust doctors and really understand perhaps both the literacy of really hard to understand why they need to do this. So also explaining why the cancer screening is important, and that is not necessarily that sentence, but they just want to keep them healthy. And then for the ethnocentrism, yeah, we don't really know anything about his like ethnic background, but we thought that because his family history of cancer, he could have been around hospitals and doctors a lot in the past, so that just because of like exposure, he's more likely to have witnessed or had that experience with doctors, or if like an influential family member did, it could have changed like the whole outlook on doctors and like Western medicine. And then the other thing is that like if a lot of the members of his family who had cancer ended up dying, you can understand why he thinks, oh, if you go to the hospital, you're going to leave sicker.
Right.
That's just his experience.
Yeah. Thanks so much, Macy. I really like the way you all discussed some of the ideas about family history and also the invasiveness of something like the colonoscopy and the importance of understanding why you would need to do this, given the sort of impact it would have on them. Move here to the second row.
The next couple of months, also trying to make them understand from his perspective why he has the fear of the doctor's office or the hospital, from like having had relatives from that, but also making him understand that he's not on diet and because of cancer as well.
Right.
Because everybody has a different perspective on how they probably die differently or at least improve with the cancer because of it. Which is to kind of make it think to understand different perspectives that we don't do. Some people are stubborn at the little, but also make them understand a little bit, not to be forced to. But then take time to them at least maybe can probably go research too, even though we had history with family members as well, and the influence of them. too is like the cancer diagnosis can bring especially like a lot more family condition, a lot of trauma. So I think you don't want to listen, you know what's gonna happen. Just
Yeah, we hear the word cancer, right? And it means a lot of different things to different people. Maybe it's, you hear it and you think, oh, it's a death sentence, there's no hope. Or maybe you hear it and say, okay, we need to immediately fight this thing, right? Depending on your experience and how you associate that word, right? That experience is going to look really different. Back over here.
So, you said that you could like let him know that it can put both him, like his and the doctor's phone. And especially let him know like how severe it could be. Look at it, and then you can also like maybe provide him with literature or something, or just give him back to like use it. And then when it goes to ethnocentrism, it could be like maybe he grew up in a household like everyone's saying where the doctors like were or like they didn't trust him too much and they had bad experiences. And then also maybe a experience like billing and stuff in the past, which can reflect on like the socioeconomic status as well.
Yeah. So I'm glad you all brought in some of the issues like socioeconomic status, associated divides and understanding and receiving care too. And then our trio over here. Mhm.
And also storytelling techniques.
Yeah.
So it's not so much
Mhm.
Also educating Carl about colon cancer, colonoscopy, pamphlets about it, and self-explorers, and just how to listen to doctors. So healthcare,
Mhm.
so like they give physicians office. But also that was
Mhm. Awesome, thanks. So in hearing you all share, some things kind of stood out to me that really connect well with what we've talked about so far in the class. First of all, this idea of patient-centered care, right? The idea that if Carl feels empowered to seek out medical information for himself, maybe we give him some URLs or links to start doing his own searching, or we give him the opportunity to look through some brochures and information. Oftentimes, people are more comfortable making health decisions when they feel like they have had the power to make that decision independently and in an informed situation, right? We've seen this a lot in the discussions surrounding COVID-19 vaccination too, that people's decision on whether or not to receive the vaccine is oftentimes one that they reach when they feel more comfortable about reaching a decision independently. Another thing that I noticed that you all shared is this idea of preventative medicine and preventative care, right? Obviously, it would reduce costs and reduce the burden if, for Carl, if he had these screenings and we were clear about the possible risks that he would have. I'm glad in thinking about ethnocentrism, you all noticed this, you feel sicker than when you arrived from it, because in thinking about or imagining his family history or background, that could explain his attitude or approach. We don't necessarily know his race or ethnicity, but we do know that he's somebody that has an experience or background of negative encounters with health, right? And we can use that information as this group here mentioned to try to create a good relationship like a provider that he sees on a regular basis. So these are all examples of some of the ways to increase health literacy and reduce the associated risks of that, right? To really identify those issues and create that as a very open dialogue. So let's go ahead and take a break for today. We We can come back at around 3:08, 3:09 or so. So feel free to grab a drink, use the restroom, see what's going on outside. We had some bonus snow, but it seemed to have settled down. I don't know. It's Oregon. It's a weird day with weather. I hear we're supposed to get the storm stuff through Tuesday, so we'll see how things go.
Oh, that was cool. I was literally. Yeah, that was cool. And I thought that, I was like, did you just get like, she just like. Or something? I remember saw two, but she's still like. I think that was like too much. Yeah, I thought I knew next year. Sorry, this one. This one's fine. You're trying to get to- And then she got two seconds in the group, this one, lots of different- this one, I guess, I think it's back to the next. But she, there's a sort of like, the diamond. Like this. Oh, no. my God, I want you to get on the front of you can happen, this, like, what are you like? Get it. It's just, you know. Well, I think that's just, you know, to make it like the 10 pictures. And it's like all about, you have to keep spiking.
Yeah. It was a long. Yeah. All right. Looks like you've got everybody back, so let's go ahead and pick up where we left off. So we were talking about some really good elements here of health literacy, how to engage in healthy and effective behavior. In thinking about this, right, and some of the issues and disparities related to health behavior, it's a good idea to think about and start to examine, right, some of those factors that do contribute to health disparities. One of them, as we've talked about, being the ways in which women, people in sort of the non-binary umbrella and anywhere in between experience unique forms of discrimination and marginalization as it relates to socialization and that experience. Again, that video we looked at earlier talking about hysteria, the way hysteria was used as a term to kind of lump together an array of conditions that impact women, putting them all under one label and not really investigating it with effective treatments or interventions is an example of these related issues. Another concern, right, is this idea of heterosexism or heteronormativity, right? The idea here being that if you're a provider, that you need to be sensitive and considerate to the fact that not every patient you're going to be working with is necessarily heterosexual or involved in heterosexual relationships or romantic connections, right? For instance, there have been stories reported by women who have been told by doctors about sort of their need to use certain forms of birth control or the pill or related forms of reducing or eliminating unwanted pregnancy. And one woman responded, well, I'm a lesbian. This doesn't apply to me. Why are you telling me this? Right. So one important consideration is not to necessarily assume the sexual orientation of patients and people that you're working with. And another thing that many members of the LGBTQ+ community report is just feeling a lack of expertise and some of the social rejection that comes with encountering some of these patient-provider relationships. For instance, in looking at the history surrounding HIV/AIDS in the United States and the efforts used to provide and develop research, there was a real fight to ensure that there was significant research to examine and support people who might receive that diagnosis, right? So there's concerns there as well. And again, in talking about issues related to racism, while we can identify that yes, there might be populations in the United States, when we break it down by things like racial demographics, that might be at greater risk of receiving, for instance, heart disease, but that's not necessarily biological. Rather, it's based on social factors, including socioeconomic status, lack of access to care, and so on, that could lead to those disparities, right? So while our bodies might not mean that somebody is necessarily predisposed to greater risk, that the environmental and social factors can play a pretty large role there too. One interesting example of some of the impacts of health disparities that is actually an example that I consider for a presentation is the impacts of things such as radiation and the ways that, for instance, nuclear testing impact populations. There's actually some studies, historical research in areas including southern Utah, where there was significant nuclear testing, and actually a documentary called The Downwinders that was about a population that had significantly higher rates of cancer that emerged as a result of the geographic location and radiation in that location too. So some of the ways that environmental factors and toxins play into risk are things to explore as well. For instance, there's discussion surrounding things such as environmental racism or the ways in which things like dumping of nuclear waste and similar materials could have disproportionate impacts depending on where that waste happens. For instance, there's discussion about Yucca Mountain and the impact of using waste sites near indigenous communities. So when we think about differences that might be related to health and things such as race, one thing that's important to identify then is the social factors that play a part in determining some of these issues. As we talked about last week with the Tuskegee syphilis study, one major issue can be distrust, right? If a population has historically had significantly worse experiences in healthcare, if we think about issues, for instance, related to eugenics and its impact on populations, and we think back to, of course, issues of genocide and ethnic cleansing, right? We think about how a lot of populations might be less trusting of the medical system if it has disproportionately done harm to that population. Possibilities, higher risk, right? Again, due to factors such as socioeconomic status, health literacy, access to health information can definitely play a major role. Additionally, lack of access to information and knowledge can play a role too. Again, thinking about access to things such as technology or information that helps somebody make informed health decisions. Ineffective patient and caregiver communication. Again, an example of this is that people might be less likely to recommend something like pain medication to people of color because of assumptions about pain tolerance. And of course, it's been found that when there is greater diversity that is represented in health and medical fields, again, including things such as race, ethnicity, gender, class, and so on, right, that as a result, patients report having more positive health experiences. That means that there is greater specialization and there are people that are more likely to get it or to understand these specific experiences somebody has. One really good example of this is in terms of counseling, therapy, and mental health services, right? A lot of times people use those services to discuss and relate to really personal experiences that are related to their identity. Finding people who are specialists who occupy similar identities to them can be a really useful way to ensure that what's being shared is relatable and understood appropriately. So I do a lot of research in areas related to disability, right? And the experiences of health and disability are really challenging to rate, right? There's a lot of factors that go into having positive health experiences related to disability. One of the issues here is that people with disabilities or disabled people, right? People could choose which they prefer. Some people prefer disabled person, other people prefer person with disabilities. Either disability is treated as the most important thing or it's avoided entirely. Again, I've worked with people who have shared that challenge where they disclose something like a diagnosis, and the minute they do, that's what a health provider latches onto or focuses on, even if they were trying to talk about something completely different. Or if it's avoided entirely, right, then that means that maybe it did play a role in somebody's health experiences. And as a result of that, it made it a lot more difficult for them to get the care that they need. One example of this, and thinking about like developmental disability or difference, would be for people with ADD, ADHD, or autism, right, who might choose to disclose because they say, hey, I'd be interested in a more sensory inclusive environment. Can we dim the lights? Could I have sunglasses? Or could things, could we talk a little bit slower, right? But might not be comfortable disclosing that because of how a health provider might react, and therefore chooses not to disclose entirely. Another major issue in health and related issues is this idea of infantilization, right? Disability in particular is historically very infantilized. That is, folks with disabilities oftentimes were adults who have very developed cognitive functions, just like everybody else, and are able to advocate for themselves, sort of get talked to slower, maybe with like a baby voice, or aren't treated as seriously in healthcare settings. That can be one major concern or issue that comes up. There's also what we oftentimes associate as the charity narrative with regard to disability, that oftentimes our approach to disability is to treat it as an inspiration, or to treat support for people with disabilities as like a charity service that makes the person who is providing that service feel good, not the person experiencing that service, right? So infantilization is an example of a problem. For instance, somebody in a wheelchair might take a lot of pride in their ability to open and use doors for themselves, and might be frustrated if somebody is constantly holding the door open for them. Sometimes disability is not relevant to a particular visit, right? So sometimes it is just not the topic of conversation, especially when we think about the idea disability is not singular, right? That disability can be experienced in multiple ways that at times could compound or impact one another. And sometimes disability brings with it assumptions about other health issues, right? Particularly the idea that you don't have this, you have this, being used to refer to people with multiple disabilities or conditions as only having one, right? Another thing that is important to think about in situating disability is the idea that for many people, disability is not necessarily visible, might be invisible or intermittently visible, right? For instance, somebody that maybe has a psychological or mental condition who might externally mask or present a version of themselves that seems fine or doesn't show any sort of signs, might be interpreted as able-bodied or able-minded in a way that doesn't get at the challenges that they might experience. So disability does not necessarily mean somebody in a wheelchair, somebody with crutches. It can mean an array of different experiences, right? We'll talk more about this at the end of the term, but the two models of thinking about disability, the medical and social model that are primarily used. Medical model treats disability as an issue that needs fixed. The social model treats disability as a product of society, i.e. we are disabled because there isn't wheelchair accessible parking, or there is a staircase when there is not a ramp or elevator, right? Those different models also help us to think about experiences in health. With children, right, with pediatric care, working with kids, it's something that many of us might find interesting or want to do. Whether or not we're doing that in a professional capacity or not, we oftentimes find ourselves in sort of parental, caregiver, teacher, mentor type role with children. Children oftentimes have greater difficulty expressing their feelings or speaking freely about issues related to health, right? That does not mean that children do not experience these challenges or are unable to express their feelings, just that depending on developmental stage, it's a lot harder for children to develop a vocabulary to explain what it is they're feeling and how they're feeling, right? So oftentimes, those concerns, also feeling a little bit anxious around adults, not being sure who is comfortable or safe to speak to, are other issues. Oftentimes, a lot of people involved in pediatric and children's care tend to be really focused on helping kids feel comfortable, helping the experience feel fun, offering something, like a lollipop for coming in for an appointment, using like wallpaper, making a very pleasant and fun experience for kids to help to make that experience a lot less anxiety inducing are ways that can help improve experiences for kids, right? Again, getting at the idea that children are oftentimes able to express their concerns about health if they're put in an environment where they feel comfortable doing so. Additionally, for children, right, one factor to consider are developmental stages, right? So at a very early stage or pre-logical conceptualization, illness is not something a child has, it's something that is happening outside of the child, right? So for instance, if they have an owie, right, or they have like a cut or a scrape, that is not part of their body. That's a thing that didn't happen to that is external to their body, right? So kids oftentimes will treat illness or sickness or injury as something that is not a part of them. And then after that, a more concrete logic understands and develops child's identity as their own being, right? Who experiences some type of health impact or issue on their own terms. And then by about age 11 up, kids oftentimes start to develop a more complex and developed understanding of illness, right? So it's important when thinking about care and issues that are facing kids to think about how developmental stage can impact how we communicate about and share health concerns with kids. I'm curious, has anybody seen the film on Netflix, I Care a Lot? Sounds like a couple people. So it's a kind of distressing, kind of thriller style film that also has some somewhat poignant things to say about how we take care of elderly populations in the United States and some of the associated sort of scams or issues with that, right? The premise of the film is that the main character, her kind of job is to take custody of elderly patients, many of whom are entirely healthy and are doing well, and to institutionalize those patients such that she is able to take over as their legal guardian and receive and inherit money from those elderly patients, right? And I'll show a trailer from this film because I think that it gets at many of the issues that we see related to health communication and age in the United States, and a larger question sort of how we treat people in an aging population and issues related to care and discrimination.
Good morning, Ms. Peterson. I'm sorry to disturb you so early. The court has ruled that you require assistance in taking care of yourself. I'm fine. I'm afraid it's not up to you to decide. The court has appointed me to be your legal guardian. Right? You have to come with me. And remember, I'm here to help. My name is Marla Grayson. I'm just someone who cares.
Marla Grayson, you've had amazing success. What's your secret?
There is no secret, Peter.
She forces them into the home, auctions off their house, and uses the proceeds to pay herself.
Because caring is my job. I will grab your chicken balls and I will work them clean.
I know what you do with your hustle. Putting all these cash cows on your wall, just leaking money into your account. Gentle Wilson, she's off. She has very powerful friends who can make life uncomfortable for you.
How uncomfortable is it?
But I'm not Chris. I don't like you.
You just met me. There's two types of people in this world. Predators and prey. I don't lose. I won't lose. You're never letting me go. Oh, you're in trouble now.
So obviously a more satirical and comedic take on this topic. And there are, of course, a lot of people who occupy a legal guardianship or try to provide similar types of services. We're doing so from a constructive and supportive place. But, right, one of the ways that we see issues come up in both media depiction and also in terms of care are questions about intentionality and support, right? In cases like this one, this is, of course, a character who is trying to prey upon or use the needs or concerns of people who might be in need of additional care. So this is an example of how we start to see issues of ageism and discrimination emerge in the health system. For instance, one issue that came up here is that the patient is saying, the older woman is saying, I'm fine. What are you talking about? I'm doing well. And then she says, that's not up to you to determine, right? I'm the person who's deciding your health or how you're doing. And that, unfortunately, about institutionalization, long-term care being put in a care home might choose to, while something like assisted living or care is beneficial in a lot of cases, that oftentimes there is fear, concern, or perhaps it isn't appropriate for that person. So ageism then means that we discriminate on the basis of age, and at times might be discriminatory or biased toward elderly patients. One important consideration here, right, is that age does not necessarily mean cognitive decline. In fact, there are many elderly patients and elderly people who will make it an effort to say, you know, I'm still doing well, I've still got everything together with my mental faculties, I'm doing well, right, and really have to make an extra effort to convey their mental clarity, especially in terms of things like informed consent. Older adults oftentimes, as a result, have greater difficulty being heard and communicating about their needs and health, right? As it relates to age, oftentimes older adults get treated as if they're younger. For instance, the use of infantilizing language, talking slowly, bending over to look at somebody, right? People may not try hard to help old people's health. At times, the assumption that, they don't have a whole lot of time left can be a really callous and disrespectful way not to respect the dignity of older patients. Treating people as helpless, right, encourages them to believe it, this idea of learned helplessness, that, oh, you need care, you're not able to take care of yourself, and not really providing an explanation or clarity to elderly patients about the care that they need. And caregivers tend to underestimate older adults' desire for information, that oftentimes more elderly patients do want to know and understand what health issues are impacting them, and at times have more of a framework to draw from when they're seeking out health information too. So again, all examples of how issues of ageism are tackled in the healthcare system, including a kind of satirical look at this, although there are instances of legal guardianships being used in an exploitative fashion, as we saw there. Additionally, what we're kind of getting at here is this idea of communication accommodation, right? And this is a theoretical approach that I think is useful in thinking about how we manage care across diverse populations. Pictured here, we have somebody that is physically leaning over to somebody in a wheelchair. And if you're not aware, generally speaking, a lot of people in wheelchairs do not like this, right? They don't like somebody physically bending over to look at them because it's like you're talking to a little kid. In fact, it's a lot more appropriate in general just to tilt your head downward, right? And not to do this very like bend over practice. That's an example of over accommodating, right? Of adjusting your mannerisms and nonverbal communication and speaking in such a way that you come across as potentially disrespectful or condescending. So communication accommodation theory says that we will change the way that we communicate to mirror or match what we perceive as the way that the other person is communicating, right? So if we're with a kid, we might talk a little bit slower, we might have a little bit more vocal variety, sound a little bit more fun, right? And it could be a good thing to change some of the ways that we speak a bit to better match the other person and ensure that what we're saying is understood and supported by that person, right? If you're going to a country that does not primarily speak English, you're going to learn a little bit of the language so that you can understand and speak with people there. You're not going to demand that everybody speaks English. But we can also show some level of difference with that person. At the end of the day, if you're a provider, you do have expertise and information that the patient doesn't have. But if we under accommodate, we're not adjusting or accounting for the experiences of somebody at all. And in doing so, we come across as disrespectful or inconsiderate. If we over accommodate, right, verbally or non-verbally, then we also risk helping that person feel unheard or unwanted in the conversation. So it's a matter of navigating that tightrope. Again, patronizing versus disconnected or too jargon heavy or not really focused on the context. So I want you to take a couple minutes just to think on your own. How might you avoid over or under accommodating how you communicate? Thinking about some of the issues of communicating with, for instance, children, people with disabilities, or maybe with elderly patients. You don't need to turn this in. I'll just ask you to take a couple minutes to think about this and maybe jot down some ideas. Take another minute or two to think about some of this. So when it comes to working with children, I'd like to hear from one or two people about some of the ways that we would avoid over or under accommodating our communication style. Does anybody want to take a stab at that? Yeah, Kate. Yeah.
And what I would do is just introduce yourself normally. We're all the continue gradually and carefully. In smaller and respectful ways that you get to know them and know how they're acting.
Yeah. Thanks for sharing, Kane. That's a really good point, right? Oftentimes, if it feels like children aren't receiving respect, they'll be frustrated or shut down. There's a lot of mature kids out there who've been through a lot. You can almost think about accommodation as like a bend, right? Where you're maybe starting at a professional level, but you're maybe slightly adjusting your communication over time based on what you're noticing in that interaction. That's a really good approach. What about disability? How might we adjust the way that we speak appropriately with that in mind? Yeah. Mhm. Mhm. Yeah.
So, basically, talking as simple as possible, but some people have different methods of talking information, and
Mhm.
others try to focus on things. Now, some people don't like to see eye to eye, but also try to look at.
Yeah.
But some people
Yeah. Yeah, it can become a feedback loop, right? Where if somebody is frustrated that they're not being treated seriously or communicated with well, they're more likely to kind of lash out or respond negatively which might make the provider like infantilize or treat them negatively more and have this entire communication breakdown. That can definitely be a problem. I know that you hit on this a little bit, but does anybody else want to take a stab at working perhaps with elderly patients in particular? What might be some things we could do to avoid over or underpublication? Yeah.
One thing I thought of is both of my grandparents, like my grandfather, like on the verge of death, like
Mhm.
can't hear anything, so I constantly have to yell at them.
Right.
So when I talk to older gentlemen, like I usually yell at them. So that's the way I overcome it, and I've
Mhm.
never.
Yeah, yeah. So, a lot of times people do feel frustrated if they can't hear. I also know that sometimes, especially with certain elderly patients, like certain voices are easier or harder to hear, right? So when my grandma was a lot older, it became my stepdad would speak for my mom or convey to my mom what she was saying because she could hear his voice more clearly. So there's definitely elements where we're translating or modulating the way that we speak, just at a basic sensory level, right? One thing that I encountered too with my grandma as she was losing a lot of her hearing was that she wouldn't tell you every time that she didn't hear, at times out of embarrassment or maybe feeling, upset that she didn't hear it, right? She didn't want to share that she didn't hear it, but pretended that she did, and so we lost some important information. So there's an element of pride or embarrassment that comes in not necessarily wanting to convey that you missed out on information. So another important consideration here about our accommodation in communication. So when we think about some of the ways that we can improve on our communication across social differences in thinking about diversity and the ways that it impacts healthcare and communication a little bit more broadly. One thing that we can think about is not to impose our worldview. Again, this goes back to the patient-centric model, the idea that the patient is empowered to make decisions about their own health and care and to do what they feel is right or appropriate for them. That's an important element, although as we talk about in public health, personal decisions that can impact public health can be a challenge. Establishing open dialogues is an important element as well, right? Presenting questions and thoughts and ideas in an open-ended way that allow a patient to share their questions or concerns or not to feel overloaded with information is really important. There's a whole subfield in health communication looking at how to share like challenging news, like, really dire diagnosis. Communicating in culturally acceptable ways is crucial, right? For instance, in some cultures, direct eye contact for a sustained period of time is not considered culturally acceptable. So ensuring that there is perhaps greater diversity and representation in things like a medical or health staff is a way to ensure that you're able to meet the needs of a greater population, also kind of being sensitive to and reflecting on your own experiences in health. Listening rather than telling people what to do, again, is a really important component here. Hearing people's stories and hearing, for instance, that Carl has been really upset about family members who have died of cancer gives us context that can help him in addressing those fears and negative experiences that he's had with health, and also empowering people to use the skills and resources that they have available, right? Again, as some of our groups mentioned the idea that people can pursue information and research on their own terms, that of course is, accurate information, but that allows them to make those independent decisions about their health and oftentimes be a lot more persuasive than doing something because a doctor told them to do the thing. So these are considerations that we can factor into as we think about health and difference. I do have a few slides related to issues of culture and starting to think about culture, but I'm going to have us talk more about that next class so that we can get into some of that in more detail and give it some more time. So I'll kind of put a pin on our discussion for today here in talking about issues of diversity and culture. And then next class, I'll have us pick up on starting to think about culture and also situating the Krebs article that talks about issues of health disparities in care overall. So we'll talk more about that next class. So to wrap up for today, just as a reminder, take a look at your schedule and your availability during May 2nd and 4th, and let me know if you have any restrictions or preferences on your meeting date. Otherwise, I'll slot you on Wednesday for those presentation times, and I'll post the rubric to help guide you on what to expect there. We talked about issues of culture and health, including the idea of communicating across difference, managing diversity in care, and supporting diverse needs in the healthcare system. So those are all things that are important to thinking about diversity in care moving forward. We'll continue to look at issues of disparities in care and also how different cultural conceptions or attitudes shape the way that we think about care too. So earlier, I had you all work on that activity where you were looking at the situation with Carl. If you're able to put your name on it and ensure that the name of your group is on that activity and pass it forward or email that to me, then we can do that for your attendance for today. Have a great rest of your afternoon. Enjoy whatever the weather decides to throw at us over the next few hours. And I look forward to seeing you again for Wednesday's class.